Kia ora and welcome to Goodfellow podcasts. This episode is kindly supported by the Royal New Zealand College of General Practitioners, the Auckland faculty. The content of this podcast was developed independently and the views expressed are those of our expert speaker. I'm Dr. Louise Kugler, a GP, and today I welcome to the podcast Dr. Elizabeth Stallworthy, providing an update on the acutely raised creatinine. When to worry? Or could this be an acute kidney injury? Liz is a nephrologist at Auckland City Hospital. Her interests include kidney supportive care and conservative management of chronic kidney disease, metabolic management of kidney stones, hemodialysis, and teaching communication skills to healthcare professionals. Kia ora, Liz, and welcome to the podcast.
Thank you, Louise.
AKI is characterised by an acute decrease in renal function that can be multifactorial in its origin and is associated with complex pathophysiological mechanisms. Liz, I wonder if we could start by defining acute kidney injury, or AKI.
The definition that we're going to talk about is the 2012 Kidney Disease Improving Global Outcomes guideline definition, which is a creatinine increase of 26.5 micromoles per litre within 48 hours, or an increase in serum creatinine more than or equal to 1.5 times baseline, which is known or presumed to have occurred within the prior 7 days, or urine volume less than 0.5 ml per kg per hour for 6 hours.
So Liz, my understanding is AKI can be further classified in 3 stages. I wonder if you could outline these for us, please.
Absolutely, it can. And with increasing stage of AKI, the risk of death and the need for dialysis increases. So that's why it's staged, why it's useful to work out. Stage 1 is where the serum creatinine is 1.5 to 1.9 times the baseline, or an increase of greater than or equal to 26.5 micromoles per litre, or urine output of less than 0.5 ml per kg per hour for 6 to 12 hours. Stage 2 is once the serum creatinine gets up to 2 to 2.9 times baseline, or urine output of less than 0.5 ml per kg per hour for greater than or equal to 12 hours. Stage 3 AKI is 3 times baseline, or an increase in serum creatinine to greater than or equal to 354 micromoles per litre, or the initiation of renal replacement therapy, or urine output less than 0.3 ml per kg per hour for greater than or equal to 24 hours, or no urine output for greater than or equal to 12 hours. The things to note about the staging definitions are that the reason for the absolute serum creatinine of greater than or equal to 353 micromoles per litre, that is basically to escalate the severity of scoring for people who've got pre-existing advanced CKD. And to meet that threshold, you have to also have had a rise of greater than or equal to 26.5 in the 48 hours, or be 1.5 times baseline within the last 7 days. And it does get a little bit grey there, because a 26.5 micromole per litre rise in creatinine in someone whose baseline creatinine is, for example, 442, is only 6%. And that's actually less than the biological variability of creatinine. So at that sort of level, you do need to look at the patient and think, actually, they look completely fine. This is just biological variability, or no, they're unwell. This is a real illness. The other thing about the 2012 definition is that it doesn't include duration of AKI in the staging, and that's known to modify outcome. So if the AKI persists for more than 48 hours, that's associated with a worse outcome.
Right. So you've mentioned the KDIGO, or the Kidney Disease Improving Global Outcome Guidance. I understand in 2023, the definition uses serum creatinine. Why do we not use eGFR?
So serum creatinine is something we can measure, and eGFR is only estimated, and it's estimated most of the time from creatinine. So after an insult to the kidneys, the true GFR will fall rapidly, and then it will take hours to days for the creatinine to rise to a steady state. And all the creatinine-based eGFR equations use the assumption that creatinine is at steady state. So there's a time lag before a creatinine-based eGFR equation will reflect true GFR again. There is actually, in 2024, a formula for something called the kinetic eGFR, which we use in hospital in acute kidney injury, to try and work out, is this person's function starting to improve yet, or do we need to put a catheter for dialysis in, that kind of thing. But to capture that changing, you need to know what the baseline was and have to recent serum creatinine values and the time between those values. So in practice in primary care, you just need to look at serum creatinine and work out how many times baseline you think it is.
Thank you for clarifying that. So patient susceptibilities and patient exposures are risk factors for AKI. So can you describe a vulnerable patient to us, and what are the exposures that we should be thinking of?
So things that can be considered susceptibilities are anything that predisposes someone to dehydration or volume depletion. So that's people on diuretics, people presenting with gastrointestinal illnesses like diarrhea and vomiting, people with like a high stoma output, for example. Anyone with advanced age. Female gender is listed as a susceptibility. It's not very modifiable. Oh, black race. Particularly look out for people with underlying chronic kidney disease. They're definitely more vulnerable, as are people with any other chronic organ disease, heart, liver, lung, diabetes, cancer, significant anemia. When you have people with those kind of predisposing characteristics, then the exposures you need to look out for are things like sepsis, circulatory shock, burns, trauma, any sort of major surgery, cardiac or non-cardiac. I think particularly important for primary care is medications. It's very important to take a thorough drug history, including things people have bought over the counter, imported from overseas, their herbal things, radiocontrast agents, poisonous plants and animals. Those are the main things. But I think in primary care, drugs, particularly in people with CKD and chronic disease.
Fantastic. Thank you. So Liz, I wonder if you can talk us through the red flags in an acute kidney injury, especially those ones that we should be aware of and have a low threshold to have a discussion with a specialist or refer on.
So I think that the serious or reversible but needs hospital care kind of level things to be looking for. Any suggestion of glomerulonephritis, so the person who's suddenly got hypertension, the person who's got hematuria, either macroscopic or on the urine sample, reduced urine output, edema, those people you want to identify quickly because their long-term outcomes often depend on how quickly we initiate treatment. Any suspicion of urinary obstruction is likely to need a hospital-based treatment, and that also their chances of getting back to baseline kidney function are better the sooner that's picked up and treated. But even I think in stage 1 AKI, so that's people with kidney function 1.5 to 1.9 times their baseline, you need to seek special advice, treat identifiable causes, review their medicines, and then review them 2 or 3 days later. Because if the AKI is not improving in a couple of days, then that also predicts that they're going to have a poor outcome and potentially some permanent loss of kidney function. So I think those people need at least a medication review, some examination and assessment of fluid status, and almost all of them should be having a urinalysis, an ACR, and a midstream urine. The only situation where I would think maybe you could skip those is if there's an obvious, norovirus infection, or if you increase their diuretics, a week ago and you discover their kidney function has gone off, then you can probably be pretty happy that it's volume related and try and fix that.
Great. So thinking about etiology for a moment now, so obviously AKI is a complex syndrome, but breaking it down into pre-renal, renal and post-renal can assist us in systematically approaching its pathophysiology and conducting investigations and management strategies. So how do you approach your patients with AKI? Do you break them down into pre-renal, renal and post-renal? Is that useful?
It's a little bit controversial. I think, yes, it is useful. It's just the important thing to remember is there's a lot of overlap between pre-renal and renal injury. If you think about pre-renal injuries being anything that starts outside the kidney but reduces glomerular function. So if people have blood loss, diarrhea, overdiuresis, they might become hypovolemic. If they've got septic shock, cardiogenic shock, if they've had anesthesia, all those things might cause hypotension, and that also reduces glomerular function, even though it's not actually necessarily damaging inside the kidneys. But any pre-renal injury that's severe or prolonged enough can then result in acute tubular necrosis and become a renal injury.
A renal acute kidney injury is one where there's damage to the glomeruli or tubules. So a rapidly progressive glomerulonephritis would cause damage to the glomeruli in acute kidney injury. And damage to the tubules could be caused by acute tubular necrosis or interstitial nephritis. Interstitial nephritis is most commonly from medications, so things like antibiotics, proton pump inhibitors, and increasingly common from immune checkpoint inhibitors for cancer.
So an example of where those things can sometimes get mixed up is if you have someone on heart failure who is on an ACE inhibitor, an SGLT2 inhibitor, furosemide, and they're also on diltiazem for their AF rate control, they can actually come in fluid overloaded but hypotensive. And if you have a knee jerk, all the creatinine's up, that must be pre-renal. They need fluid and cut their diuretic. You might actually make things worse because they need their volume overloaded treated, and they might need one of their blood pressure lowering medicines temporarily reduced so that their blood pressure can rise and they can perfuse their kidneys better. Medications also can cause pre-renal insults. So medications can contribute to kidney hypoperfusion either by lowering blood pressure or by altering the hemodynamics inside the glomerulus. That's classically non-steroidal anti-inflammatories cause afferent arterial constriction, and then your kidneys are not able to adapt to changes in blood flow as well. And similarly, ACE inhibitors dilate the efferent arteriole and thus also reduce the ability of the kidney to compensate for hypoperfusion. And that's where the whole story about the triple whammy effect, that people on ACE inhibitors, diuretics, and non-steroidals are especially vulnerable to pre-renal AKI when they have another health insult like a serious infection, because their kidneys can't compensate for changes in renal blood flow.
We haven't touched on post-renal causes or etiologies. So any comments there?
Post-renal is obstruction of the ureters or the urethra. It's very important to consider in someone who's got renal colic and a raised creatinine, or when there's urinary catheter, which might be blocked, or in the otherwise well older person with AKI, no proteinuria, who may or may not have hematuria. In those people, you're wondering about their prostate or the possibility of malignancy.
Fantastic. So just sticking with the pre-renal, renal, and post-renal, what percentage of acute kidney injury would fall into each category? I understand now that there's an overlap, but can you make some generalizations about those numbers?
So I think this is dependent on the setting in which you work, but pre-renal is probably the largest group. Some people have suggested kind of 60%. Renal causes more like 40%. And post-renal is much less common unless you're a urologist, probably.
Perfect. So moving back to our primary care practice, we have someone who's come in and we suspect they have an acute kidney injury. What investigations do we need to order, and how urgently do these need to happen?
So I think that you need to be checking their blood tests, particularly their creatinine, sodium, and potassium the same day if you suspect an AKI. For many patients, if they're going to the lab, you should get them to do the urine the same day. As I mentioned before, if there's a very clear hypovolemic trigger, then you could just arrange for them to do urine tests when you send them for their follow-up bloods a couple of days later. The importance of time is just to highlight again that if it's not improving in 48 hours, that predicts someone has got a high risk of a long-term consequence, a bad outcome from this. In hospital with significant AKI, we very frequently do ultrasound. I think probably if someone is sick enough to need hospital, they should be sent to hospital. If they're not sick enough to need hospital, then mainly in primary care, you would be doing ultrasound if you were suspecting obstruction.
And how quickly should that ultrasound happen, ideally?
Really, I think if you can get an ultrasound within a few days, maybe if you're not completely sure on the timing of onset of the injury, you could stretch that out to a week or two. But if you think that this change has happened within 48 hours, I think you'd be wanting the ultrasound within 48 hours.
Perfect. Yep. Great. Thank you for clarifying that. So moving along now to management, which of these patients need to be referred acutely to hospital?
So remembering that at least 50% of AKI begins in the community, so they are often people that general practitioners will identify and send in to us. Clearly, if there's a stage 3 AKI, so that's creatinine more than 3 times baseline. If there's a stage 1 or 2 AKI and the underlying cause requires hospital treatment, so septic shock or even just bad sepsis needing IV antibiotics, or fluid overload where you think they're going to need IV diuretics, a potassium of 6.5 or more, And then anyone who's got stage 1 or 2 who's getting worse or not getting better after initial management in the community, so that 48-hour point. Then other special cases are any renal transplant patient with an AKI, a suspected GN, because just to mention again that usually, or for most causes of GN, the more prompt treatment initiation is, the better the long-term outcome. With acute interstitial nephritis from a drug, so that's kind of a hypersensitivity reaction rather than a glomerular hypoperfusion insult, I think that probably should be managed in conjunction with a specialist, but depending on the severity of the injury, could be inpatient or outpatient. Baseline kidney function is going to be a factor in deciding whether the person needs to be referred to hospital. If someone was in stage 5 chronic kidney disease already, even with a stage 1 AKI, a rise in creatinine of like 1 and a bit times, then they're going to be getting pretty close to running into trouble with metabolic acidosis and hyperkalemia and fluid overload, so they're more likely to need supervision in hospital. If you suspect obstruction, people should be coming to hospital. People with a single kidney, you should have a lower threshold for thinking, does this person need to be monitored in hospital? On the other hand, people who've got a stage 1 or probably even a stage 2 sometimes insult that is clearly related to diuretic or cardiac medication, if you think that you can correct the volume in the community, if they can drink or fluid restrict, whichever way around, then you can probably keep those people in the community for the first 48 hours at least to see whether you can turn things around.
So that brings me on to my question about community management. So you've mentioned fluid status. What other things should we be considering as we're managing these acute but less severe patients in the community?
Just my little plug about fluid status review before we move on from that is I really strongly encourage people to weigh patients, because an awful lot of fluid assessment is subjective. However, if you know that before you increase the person's diuretic, they were 67 kilos and they're now 60, then you can feel pretty confident that that's fluid deficiency. The other things that, if you think about the AKI definition, monitoring urine output, I'm not sure how practical that is in the community, but definitely if a patient says they've noticed they're passing less urine, I think that probably could be added to our list of red flags, and how long ago that was, you need to consider as well. Medication review is really important, and withholding medicines that reduce glomerular filtration and reducing or withholding those that require dose adjustment for reduced kidney function. So don't forget things like gabapentinoids and metformin. I guess it's more preventative, but it's very important to give sick day advice about ACE inhibitors, ARBs, SGLT2 inhibitors, and non-steroidals, especially regular users of non-steroidals. Any of those things you want people to be withholding if they turn up and you think they're already in an early AKI, ideally before they get to that point. Then I think at the 48-hour point, you want to check their electrolytes and creatinine again so that you can refer them to hospital in a timely fashion if things are not improving. If you didn't do a urine with the initial bloods, I think you can send them along for that. And just remember that you're looking for red cells as a query GN, or less commonly like an obstructing tumour or something. And you're also looking for sterile pyuria, which is you can find in acute interstitial nephritis. Oh, and then there's the consideration of, do you think obstruction is, are you suspecting obstruction, in which case you can request a renal tract ultrasound if you can get one promptly.
Yes, indeed. And getting a scan in a timely manner is often something that will prevent us from keeping people in the community. So thinking now about prognosis, prognosis is poor post-acute kidney injury episode and morbidity is increased. I wonder if you can talk us through that comment.
Yeah, so large studies have shown that even small rises in creatinine are independently associated with increased mortality. And the 26 micromole per litre rise in the definition of AKI from KDIGO actually comes from a study which shows that this rise, kind of funny number that it is, was found to be independently associated with a 4-fold increase in in-hospital mortality. And it was a study with 10,000 patients in it. As I mentioned earlier, the higher the stage of AKI, the greater the risk of mortality and eventual end-stage kidney disease. Not all AKI is created equal, though, and the magnitude of the mortality risk is modified by the clinical setting in which the AKI occurs, the person's baseline kidney function, whether they have diabetes, coronary heart disease, and also the duration of the acute kidney injury. A large systematic review and meta-analysis found that mortality risk was greater for AKI after angiography, followed by cardiovascular surgery, followed by hospital inpatients, and interestingly, in the ICU setting had the lowest risk. An episode of AKI is also associated with increased risk of chronic kidney disease, cardiovascular events, heart failure, hospital readmission, and fractures in the long term. The data on this is observational, so not all of this excess risk is due to the kidney themselves, and the occurrence of AKI is probably also a signpost of more vulnerable, often multimorbid patient groups.
So with all of that in mind, Liz, what should we be doing in the long term to manage our patients post-AKI episode?
So interestingly, there's no current standardized definition of what's appropriate follow-up after an acute kidney injury, and there's a lot of variation in practice. The 22nd Acute Disease Quality Initiative meeting proposed a more comprehensive version of their annual kidney health review to be done post-AKI, and they called it CAMPS, K-A-M-P-S, which is checking kidney function, K for kidney, creatinine and proteinuria. The A is for advocacy, so that's about educating the patient and caregiver that they have had a kidney insult and the implications of this, and communicating that this event occurred with other providers. The M in CAMPS is for medications, so that's reconciliation, review, management, and specific discussion of the risk-benefit of things like ACEs and ARBs, mineralocorticoids and diuretics. The P is for pressure, so that's blood pressure and euvolemic weight. And then the S is for sick day protocol. So very important, because we do want people who've had AKI to go back on their ACE, ARB, SGLT2 inhibitor most of the time. I'd be hoping most of them didn't go back on their non-steroidals, but I think patients often choose to do that anyway. But it's really important that they know that if they get sick in the future, they need to stop taking those things when they become significantly unwell. So anyone who can't eat and drink normally should be withholding those medicines if they're sick until they can eat and drink normally again. The Acute Disease Quality Initiative meeting also suggested then follow up at least annual kidney health assessment for people at high risk of AKI. And so anyone who's had a previous AKI is at high risk of another one. And their acronym for that was an ABCD. So A was AKI history, B is blood pressure, C is CKD, which basically means creatinine, what's their level of kidney function now, and the D is for drugs and dipstick. Dipstick in this setting and kind of chronic follow-up of someone who's had an AKI is looking for development of proteinuria, which is a sign that they've developed CKD or their CKD is potentially progressing if it's getting worse. And they suggest that you repeat this assessment before an anticipated high-risk exposure. So if somebody who's had a previous AKI has got a coronary angiogram planned, they do it before, and then 2 to 3 days after the exposure. If someone has an unplanned high-risk event and they've had a previous acute kidney injury, then, so for example, if they get norovirus, then they suggest as soon as you see them, you do the kidney health check, the ABCD. They're very into acronyms, this group, and the other thing they had was the 4 M's for after a high-risk event in someone who's had a previous AKI. That's medication adjustment, minimize exposure, message the care team and patient, and monitor. So I think what they mean there is, for example, I recently saw a man in hospital who did a severe AKI after surgery, and there'd been a contrast scan and the whole mix of things that contributed to his AKI. And then I noticed that he was scheduled just coincidentally for, I think it was an angiogram of his leg about a week after he was being discharged. And so I contacted the vascular surgeons and interventional radiology and said, look, could we just push that out by a couple of weeks to give him a chance to recover from this episode properly before we start, exposing him potentially to further insults.
Perfect. Thank you. So we've got CAMPS, A, B, C, D, and the 4 M's. We'll store those ones away. Thanks, Liz. So it's been wonderful talking to you today. To conclude our podcast, your take-home messages for our listeners on acute kidney injury.
Medicines. A lot of people who have acute kidney injury are on medicines that predispose them to those. Assess volume state, and as I said, if you know what someone's baseline weight is, that's very helpful when they come in with a history that suggests dehydration or hypovolemia or fluid overload. Test the urine, looking for blood and protein, and repeat the kidney function within 48 hours to check they're improving. And please, 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 when prescribing ACE inhibitors, ARBs, SGLT2 inhibitors, and non-steroidals, including celecoxib, give sick day advice.
Fantastic. Great take-home messages. Thank you very much, Liz. If you're a New Zealand GP and would like to claim CPD points for listening to this podcast, our podcasts are eligible, so please log them. You'll also find a list of resources used in making this podcast on our website, goodfellowunit.org. Thanks for listening.